had great questions. We're going to get to them now. Please join me as we introduce our wonderful panelists. Come on up. Dr. Kutilek, Dr. Poole, both with us. But these are all your questions, so we want to get to them. Okay. What is the current recommendation on when we should begin having mammograms? And does a family history of breast cancer impact that?
Generally, we follow the American College of Radiology. It's the simplest one. Once you turn 40, annual mammography. When do you stop? It's basically, if you're healthy, a lot of people say around 75, you should determine, hey, are you healthy enough to get screened? I think if you have 8 to 10 years of life expectancy, mammography is still warranted and can be helpful. There are other organizations that say, from 40 to 50 every year, every other year, top-tier physician. Pretty much it's uniform from 50 to 75 annual or every other year. But we go by annual mammography. Our clinicians in the health system do a wonderful job, like Dr. Westcott did, making sure women got their annual mammogram.
So 3D versus 2D.
3D versus 3D. 3D is called what we call breast digital tomosynthesis, and what that is slicing the breast so you can detect abnormalities easier. I think in the United States about 40% of the mammograms have DVT, so it's really caught on fire. All but one of our units are digital breast tomosynthesis, so it's another step. It helps us detect. It also decreases our callback rate. We think we see something on the 2D exam, we look at it on a 3D, that doesn't look like anything. So it can decrease that callback rate, and it also increases detection. So it's a wonderful technology advancement.
So that one that's 2D, is that at Regency?
That is at Regency, and from what I hear, it will be replaced next year. So we'll be.
That is correct. The foundation gets the
I have confirmation.
We do. Okay, how do I prepare for a mammogram? I know that sometimes people think it's weird when you go in and they have those little warm towelettes and they say, take your deodorant off. Why do I have to take my deodorant off to get a mammogram?
The deodorant or anything that has talc can cause artifact. It can look like calcifications on the mammogram. So that's why we discourage the use of that. And we clean up the breast as best as we can. And if the technologist sees something, say in the armpit, a lot of times they'll have to wash it off and then repeat it easily. So that's the reason.
That term, dense breast tissue. Anyone heard that?
Yes.
Dense breast tissue. When we look at a mammogram, we're going to put what type of breast density you have. Everyone is different. There's a fatty replacement pattern, which is the one I love to read because we're more sensitive to detect abnormalities in that fatty breast. Then there's mild residual tissue, which is that's probably the most common. Heterogeneously dense, that's over 50% of the breast has some breast tissue. Breast tissue is white on the exam. And then very dense, where over 80% of the breast has dense breast tissue. Problem with breast tissue is that it has the same density as cancer. So that's why cancers can hide a little easier in women with heterogeneously dense breasts. That's where DVT really has an advantage, because we can sort through that a lot easier and detect subtle abnormalities that we don't see on the regular 2D image.
Dr. Poole, you're nodding. Anything you want to add there?
I mean, I agree with everything that Dr. Kutilek said. Of course, he's the expert on breast imaging. He talked about 40 starting with mammograms. I don't know how you feel, but with seeing younger and younger women, I would not be surprised at all if in the next few years we see that decrease down to 35. I think with the younger and younger women, with family history, that certainly plays a factor as well. If you're found to be over 20% lifetime risk for developing breast cancer, that puts you in the high-risk screening. And so if you have family members and you're over that 20% lifetime risk, then generally we recommend starting your breast imaging 10 years earlier than the youngest person in your family that was diagnosed with breast cancer. and we see patients in the office that are high risk. If you just have that family history, we're more than happy to see people to do breast exams. If we think they're ready to start their breast imaging, getting that imaging started as well.
Yeah, and then also, patients with high risk, we also throw MRI, breast MRI into the arena, and that, it's totally different than mammography. We're giving contrast, and cancers take up that contrast, and even with a very dense breast, we can see it so much easier on the world. So a lot of times we'll alternate, an MRI, then 6 months later do their digital breast census, and then 6 months later we're kind of follow up every 6 months with imaging.
The other thing I wanted to add about, preparing for your mammogram, it's pretty easy to show up and get it done. It's not like a colonoscopy for colon cancer screening where you have to do a bowel preparation the night before, and then you have to have somebody that can take you and bring you home afterwards because you're getting sedation. So, it's pretty easy to just show up, get it done. I tell my patients all the time, it's a gentle squeeze, which I feel like they all look at me like I'm not 40 yet, very close.
Have you had your mammogram?
I don't turn 40 until December.
I got in the machine and had them press me, so I know what it feels like. I want to know what you're going through. I think the tech got back at me because she squeezed me pretty hard.
Bless your heart for that gentle squeeze.
I tell them all the time, they look at me and I'm like, I know, you think I'm being really cute right now, I know.
Okay, what about the dreaded callback? Right, the callback comes and you've seen something and you can't usually get in for a couple of days, and there's the panic that comes with that.
Yeah, that's the hard part. That's kind of one of the harms of mammography. In our practice, about 7% of our women, we see something that could be an abnormality, and we call that a BI-RAD serial, or additional imaging is recommended. Usually they come back for additional mammographic images, and then maybe ultrasound to follow. 9 times out of 10, that turns out to be something benign, an cyst. So it is scary, and that's one of the things that I like. When I come into a patient, what's this doctor coming in? What bad news? And generally have good news. It's something abnormal. Probably out of the, say, 100 callbacks, maybe 5 or 6, I know they're cancer. And we're calling her back to work it up. But the vast majority of times, it's benign things or something we see on 3D that, are new, but they look benign, but we just have to prove they're not a solid nodule. And we call you back. And usually we have good news. It is scary because you're thinking, oh my God, we always think the bad. It's like, oh God, what they see, it's good, I got cancer. But the vast majority, that's what I tell, particularly women that have cysts, I go, you're going to get called back probably a lot because you're a cyst former. And that doesn't increase your risk for cancer or anything, but it confounds the exam that we do, because we'll see these new nodules and we generally have to work them up. So, it's scary, but most of the time it's going to be fine.
Good thing to remember. Get a little reprieve. Okay, Dr. Poole, what are some of those early signs of breast cancer? We talked about the history, but can you just kind of go through the list?
In general, for an early breast cancer, you're not going to have any symptoms. Ideally, we're going to find it before you even notice anything, and you're going and getting your mammogram done every year. Things that we do see sometimes, and I feel like sometimes it's just divine intervention at times, that somebody will have some breast pain and they'll come in for some diagnostic imaging, and it's not that the cancer, oftentimes it's a teeny tiny thing that we find, and that's not going to cause you any pain or discomfort, but something prompted you to go in, and so I think sometimes that's just divine intervention. But certainly, more advanced things, we can see some breast pain, certainly if you feel a lump or bump, sometimes some nipple discharge. Those are some of the things that we see. Any skin changes, if you feel something dimpling, pulling in, changing like the shape, the contour of the breast.
But it sounds like you're a believer that if you think something might be going on, even if you can't point to it, go in.
Absolutely. And again, I think as women, moms, we feel like we're wasting somebody's time going and getting something checked out, but it's probably nothing. And so sometimes people will sit on it and think, well, it's fine, it's nothing. If you're concerned at all, get it checked out, and you are absolutely not wasting anyone's time by doing that.
Hereditary risk. Someone in your family or someone's in your family has breast cancer. You talked about it before and how that can change when you get your mammogram. What should you know? Sometimes we don't know what we don't know. Not everybody knows their family history.
Yeah, absolutely. I mean, families obviously are complicated, and I see it all the time that people are like, well, we don't really talk to one another, we don't really know what's going on, we don't know ages, I know that somebody had a mastectomy, but I don't really know why they had that happen. So I think the more that we can be open with one another and our families and talking about those things and knowing more detail about, what happened. I mean, honestly, most breast cancers are not, you're not going to have a gene mutation that predisposed you to that. I mean, most women don't have that. So women that certainly have that family history does put them at an increased risk, and so it's important that you know that so you can share it with your physician and they can get you appropriately screened and keep an eye on you.
Both of you referenced this earlier, seeing cancer in younger and younger women, breast cancer. Can you draw any conclusions as to why?
When I see patients, I tell them, there's three things that we think, result in breast cancer. So one certainly would be a gene mutation. If you inherit some gene that puts you at increased risk for breast cancer. Second thing would be, were you exposed to something during your lifetime? Did you have chest wall radiation as a child because you had lymphoma? Did you get exposed to some sort of chemical? And then the third reason, we don't know, which is scary.
Yeah, I don't know. I mean, it's probably a combination of things. Environmental, a healthy lifestyle.
One of the things that you talked about was breast, just pain, discomfort. Sometimes the breasts just hurt, right? Especially kind of in the cycle of going through pregnancy or going through menopause.
Absolutely. So, it can vary, like you said, with your cycle. Sometimes you have breast pain. We don't have a clear explanation for why that is. I tell patients all the time that I'm sure that there's some people, every time they have a headache, they think, oh my gosh, I have a brain tumor. But, most of the time, that's not the case. And kind of the same pain with breast pain. So I think it's important, if you're noticing when it's happening, if you're seeing any association with your menstrual cycle. I tell people, all the time, it's important to make sure that you're wearing appropriately sized, fitted, supportive bra. That can help with breast pain. We think there's an association with caffeine intake. Everybody had coffee today, with caffeine intake and fibrocystic breast disease that can result in some breast discomfort as well. So, I think keeping an eye on it, and again, if you're getting concerned about it, I see people all the time for breast pain.
Yeah, we still image breast pain. We rarely find anything, but it gives the patient calmness that, hey, we don't, at least we don't see any evidence of cancer in the breast. We don't know the cause of it. That's always the problem. It's like, geez, doctor, why do I have this? We really don't know, but the good news is we don't see anything that looks bad.
Treatment for breast cancer, how does it change depending on the stage that it's caught?
So there's a lot of factors that go into appropriate treatment. When I see patients in the office, I break it down into local therapy, which is treatment to the breast. So we're talking about surgery, radiation, and then there's systemic treatment as well, which depending on if you're estrogen receptor positive or not, there's anti-estrogen therapy, which would be a pill. There is what I describe as biologic therapy, which would be Herceptin if you're HER2 positive, and then there's chemotherapy as well. And I would say, in general, everyone needs surgery unless you're not deemed to be a surgical candidate. And then radiation is really dependent at times on which surgery you choose to do, but we also take into consideration the size that the tumor is, as well as the lymph node status and then margin status as well. And then as far as the systemic therapy. They're saying, if you have a triple negative breast cancer, you're going to get chemotherapy. If you're HER2 positive, you're going to get chemotherapy. But there's a lot of women, and I'd say most women, that are estrogen receptor positive, HER2 negative, that there's not really any clear indication that you need chemotherapy. And we really found with breast cancer that it's the biology of your individual cancer that determines the benefit of chemo. And so we actually do the surgery, find out, okay, what's the size, what's the lymph node status, and if we don't have any clear indications based on those things that you would need chemotherapy, then we do additional testing on the cancer itself, where we're looking at 21 genes from your cancer itself. So it's very individualized to you and your cancer to see if you would benefit from chemotherapy or not. So it's very individualized therapy for patients, and that can be hard because women love to talk, okay? And so you get a cancer diagnosis and you're talking to your friend who's talking to their friend, and everybody has an opinion about what you should do, and well, my friend had this done, and I don't understand why they had this done, and you're not having that done, and they must be wrong, but it's very individualized. No two cancers are exactly the same.
It's just amazing how far we can come. I'm an old guy, and I remember we used to read sterile mammography with these blue images, and if someone had a lump, the surgeon would stick a needle into the lump. If they didn't get fluid, you went to the operating room. If it was cancer in the operating room, you might lose your breast at that point. Now we can work things up. We're screening much more effectively. We're finding smaller cancers that are curable. Our lumpectomies, not everyone's getting a mastectomy. We have radiation. We have targeted therapies. It's just amazing how far we've come, because breast cancer used to be a death sentence. It used to be like pancreatic and lung. And but now it's a very treatable disease. So it's been amazing during my career how far we've come. So there's a lot of optimism.
We talk at breast surgery conferences all the time about how we think someday, and I don't think or hope in my lifetime that will be the case, but that someday the surgeon won't even be involved in the treatment, that we're going to have other treatments available that you don't need to have surgery. I think we're a ways away from that, but we talk all the time at these conferences about how we have to find a way to keep our kind of selves in the game, that surgery is going to be unnecessary.
And then it's amazing to see, neoadjuvant therapy. A lot of times, with advanced disease, they get treated, and then, on their final surgery, hey, no cancer's identified, and so it's amazing.
So chemotherapy up front, if we know based on the tumor biology that you would benefit from chemotherapy, we will do chemotherapy first, and then that can help to decrease the size of the cancer. Maybe you weren't a candidate for a lumpectomy initially, but now you do your imaging after chemo, we don't see anything radiographically, and then we take you to the operating room and are able to do a lumpectomy, and sometimes we don't find any residual disease at the time of surgery, and that's the best when that happens.
There's a lot to be encouraged about in terms of how far we've come. We often think about breast cancer and think women, but that's not necessarily, obviously men can be affected as well. So talk to us about how that looks, how that presents. Is there anything different other than?
Yeah, so men can certainly have breast cancer as well. Doesn't really present any differently than it would in a woman, but the thing is men aren't really looking for it. And so oftentimes it presents at a more advanced stage because they're just not paying attention to that.
Yeah, about 1% of the breast cancers are in males, and usually it's a hard palpable lump. Most of the palpable abnormalities turn out to be gynecomastia, or just overgrowth of normal breast tissue in male, hormonal or pituitary issues or medications. But it looks, we'll do the mammogram, we'll do the ultrasound, and the cancers look similar to cancers. So, but it is, like you said, usually it's a little more advanced. It's been there, guys are guys. It'll go away in 6 months or whatever. Why work it up until something's happening or it's like starting to crawl through your skin? So we're a little more stubborn. So that's why having gatherings like this and promoting breast health is so important.
So you have to give someone the news that they have breast cancer. can't even imagine the questions that come after that.
There's a lot of questions, obviously, that come up. I try to, when I see patients, go through their pathology report, line by line, going through everything with them. It's a very detailed conversation. I generally spend at least about an hour with the patients. A lot of times they have a list of questions for me that if they kind of let me go through everything with them, that I really touch on most of those things. But yeah, I think everyone wants to know, what's the long-term prognosis? Am I going to die from this? Am I going to need chemotherapy? What surgery? I think we all immediately go to that worst-case scenario and think, I'm going to have massive surgery, I'm going to have chemotherapy, I'm going to be deathly ill, I'm going to lose my hair. And there's certainly people that have to have kind of all of that treatment, but there's lots of women that we diagnose at an early stage where it's very treatable and can be really minimal, really. We're doing an outpatient surgery with a lumpectomy, sentinel lymph node biopsy, you're doing radiation as an outpatient, and radiation, you're not going to get sick with radiation, you're not going to lose your hair with radiation, and then after that it's a pill that you take for a number of years. And so a lot of women can have that experience. There's certainly some women that, that you have to do everything. You have to do chemotherapy, and they, aren't a candidate for a lumpectomy and have to go through a mastectomy. But a lot of women, it can generally be a pretty easy process. And my goal and hope for everyone is that you come back and tell me, gosh, I still to this day can't believe that it was cancer, because everything was so easy. And I've had, people that have come back and said that, and I'll tell people that this is what I hope for you, and I've had people that have come back and said, I know that you told me that you were gonna hope for this, and I didn't really believe you, but now you're right. Everything was so easy, and I can't believe that I had cancer, and I'm through it.
Knowing that's best case scenario, right, and everyone's journey is different, how do we as women support the women in our lives who are going to get that diagnosis? What have you found to be helpful through that treatment journey? What do people need?
I think it's listening and being there as a support person. Oftentimes we want to give our opinion, we want to fix it, but that's not what people need sometimes. They just need that ear, somebody to help them. I have some younger patients that have young children. They don't want to burden anyone with any of it. They don't want the help. But I think the more that we can just be there to support one another is really the key.
Question for you. Is the internet helpful or harmful?
It depends. It depends, I think, on the sources that patients are looking at. I think there's a lot of things out there that they can find. We have this wonderful thing called My Best Care, where patients are able to access their results sometimes before I've even had the opportunity to review them. And so they get that cancer diagnosis, but there's lots of things about their cancer that we don't necessarily know yet. And so there's lots of questions that come up because they know that they have cancer, but there's more information yet to come. But then they go through, their search on the internet and kind of, go down this rabbit hole, scaring themselves about what they're seeing. So that's challenging. I think support groups and especially online support groups can be difficult at times as well, because everybody has an opinion and has their own experience. And again, as women, we like to talk and we like to share those things, and we think what we did for our breast cancer was the best thing ever, and everybody should do what we did. And so Sometimes we have people that get on those support groups and then get very opinionated about what they need to do, but it's like, but the person that you're talking to doesn't know the ins and outs of your cancer, doesn't know what your estrogen receptor status is, doesn't know, you know, the HER2 and all of that as well. I mean, I had a patient recently that was diagnosed with DCIS, which is not invasive cancer, does not need chemotherapy, and she got through all of her surgery, we were all done, and then I got a message later like, what was my onco score? And I was like, we don't check an oncotype score on, you know, non-invasive breast cancer, but you know she was in some group that was talking to her about and asking her, well, what was your score?
We are not going to get through all these questions, but I will promise you that we will get all the answers to you. We have everyone's email address, so we will just go through with both of you. I know that you'll be generous with your time, not today, but later, next week. We can put the additional things together, but I do want to give some time, if anyone, sometimes you hear something and it does prompt a different question that I don't have down on paper and can't get them to answer. So if someone has a question, now would be a great. Dory.
Okay, so I've heard, so two things. One is ovarian cancer connected to breast cancer, because I've heard that. And two is estrogen connected to cancer, because I've heard that as well.
You guys both hear the question?
Yes.
Okay.
Yes.
Yes.
Yes. So yes, there is an association with ovarian cancer and breast cancer. So we talk about the BRCA1 and 2 genes. So there's an association with breast and ovarian cancer. So if someone in your family has ovarian cancer, that could potentially put you at increased risk for breast cancer as well. And I think really, and Dr. Westcott could probably answer this question better than I can, really any woman that's been diagnosed with ovarian cancer should have genetic testing done to see if she's a carrier for that gene. And as far as estrogen, yes. So most breast cancers would be estrogen receptor positive, so it would be driven by estrogen. So we talk about anti-estrogen therapy. So yes, association with estrogen. So we're really looking at, when I see patients in the office, we talk about, you know, when did you have your first period, and then when did you go through menopause? And if you started your period at a very, very young age and then had menopause late, then you have had this, you know, prolonged exposure during your lifetime to estrogen, and that could put you at increased risk for breast cancer.
And that begs some of the questions still on the paper about menopause and estrogen and hormone replacement therapy. So we'll get all those answered for you. Last question, anybody? Oh, two more. Okay, Linda?
When women are going through breast cancer and post surgical and chemo, what kind of advice do you give them about nutrition going forward? And do you talk about that at all?
So I talk about it some. I think, you know, making sure that you have a well-balanced diet, low in fat, making sure you're getting plenty of fresh, you know, fruits, vegetables. We do have nutrition, dietary services that we can refer patients as well, and oncology would have that as well. So I mean, I would love to say that I have a great diet, but I'm a busy mom and a surgeon, and so I don't always eat well, so I don't always feel well equipped to counsel patients on that, but certainly if people have questions, we do have resources available to them that we can refer them and help with that.
One of the things that we do have, and you can do this whether you're a patient at Methodist or a patient somewhere else, you know, at a different health system, is Harper's Hope Cancer Survivorship Services, and they do have oncology dietitians there. So Dr. Poole, you don't have to be the expert, right? We do have those. And there was a lady back there in a pink hat that had a question.
Yes. What about second opinions? How important is it to seek another opinion on your specific disease?
So I never think that it hurts to have a second opinion. I would say in general, I think you're going to get the same information and opinion as far as your care goes, but sometimes getting the information again and having it presented in a slightly different manner can really help you to understand things a little better. When I see someone as a second opinion, I don't look at it as an opportunity to steal a patient or to, you know, the other team that's looking at you to kind of argue and say what they're proposing is incorrect. I think my job is more to say, yeah, that is a very reasonable, treatment option. I agree with them as far as the treatment plan goes, and really then it's up to you as far as where you want to go for your treatment. But I never think it's a bad idea to get a second opinion.
Well, I think it's a great idea. I mean, you have to be comfortable with the decisions you're going to make, and the more information you have, the better. I encourage second opinions on, the mammogram, ultrasound, and, particularly if we're following something. Hey, I think this is benign. Let's do a 6-month follow-up. And if they know someone, it's like, yeah, go over to UNMC or CHI, have them look at it, see if they agree. If you get a couple radiologists who agree, it's probably right. The hardest thing I do in radiology is mammography, because every mammogram is different, and cancers don't always look the same. So it's the hardest thing I can do.
Please join me in thanking Dr. Poole.